You might remember that this is not our first consumer consultation. We went out in the first half of last year of 24 and did a consumer consultation through our support network, through our extended network at PCFA. And we received a significant feedback from them, over 70 submissions. What we know is, and happily, we've managed to get that published in the Journal of Surgery. In fact, the ANZ, Australian New Zealand Journal of Surgery. And it reports what consumer desires and needs were. So what we will do is, and we already have, is folded in a lot of that research into much of our implementation priorities, which you see in the guidelines. So it is important, this consultation phase, that if there are things you feel you want to say, if there are things you think need to be added to the list of considerations and issues, or if there are things you want to emphasise, please do take the opportunity. As you know, the consultation period is open until the 25th of May. Importantly, we've had a group of about 60 experts in the field contributing into various committees. Some of you are on the call. Can I just point out for you that when you actually analyse the experts that we've had on various working groups, committees, advisory groups, panels, steering committees, etc., the three biggest groups of experts are GPs, urologists, and consumers. And to be honest, we've had more consumers. They're actually the top subgroup. So we've had the number one represented group in our working groups has been consumers. Number two is urologists, and the third group are GPs, which are all critical to us. So consumers have already had quite some say in how these guidelines have been put together. In terms of broad transitions, I just say before passing on to Peter, a couple of things about broad transitions. These 25 guidelines take us from, a focus on testing, which the 2016 ones were, to a more broadly based, risk-assessed, harm-minimised approach for the early detection of prostate cancer. And secondly, the second transition is shifting from a discretionary / opportunistic testing program to one that is more of an organised testing program. And much of the discussion has been around those two transitions. In terms of the guidelines, there's two major parts. There's the actual guidelines themselves, the clinical practice guidelines, which have the recommendations, and we will talk about those in a little while, and Peter will address those. There are also, which are critical, some priority and implementation priorities. And I do remind you that they're there, and to take the opportunity to comment on those as well, because these are the sorts of things which you have told us previously through various mechanism and channels about which you have told us previously about what is important about implementation, about consumer companions, about education awareness, about making sure GPs are educated as well, about all of these things. So let's make sure that if you've got comments about that too, please look at those implementation priorities. About just some helpfulness about the consultation today, about our meeting today. If you're not speaking, can you please try to remember to keep yourself on mute? It just helps from a sound quality point of view, just so we make sure that we can hear what people are saying. If you can, and you want to make a statement, you can do it in two ways. You can put in a comment. I see there's already a couple of comments coming in, so that's terrific to see. Or you can raise your hand when we get to that part. So we'll hear from Peter and we'll hear from Anne, and then we'll go to a question and answer session. You can raise your hand or you can send a comment. Can I note we only have an hour? If there are questions that you have which we don't get to cover today, that's okay. Just send an email to us at research@pcfa.org.au and we will get back to you. What I might do now is actually introduce Peter. We'll hear from Peter, then we'll hear briefly from Anne about next steps, and then we'll go to question and answers. Hey, so why don't we do that? Peter, if we can throw to you as a eminent urologist, practicing urologist, can you perhaps talk to us from your perspective about the major changes in these revisions and what it means for clinical practice in Australia, and then what it will mean for outcomes for men? Thanks, Peter.
Thanks, Jeff. Good afternoon, everybody. The major changes come in two tranches, if you will. The first is what's been happening in the last 10 or 15 years in clinical practice, in urologic practice, in general practice, and then the changes that the literature and clinical practice have informed, how they've informed our changes in the guidelines. Jeff's already mentioned it. We're no longer talking about PSA guidelines. We're talking about guidelines for the early detection of prostate cancer, and moving from a disorganized, opportunistic approach to, over the next few years, an organized testing program. But the big changes in clinical practice that have affected me, looking after men and their families with prostate cancer, has been harm minimisation as well as risk adaptation. In other words, we're looking closer at family history, at history of any cancers within families, history of prostate cancers, the BRCA2 gene, of course, and others, but also harm minimisation. We work in a fantastic medical system in Australia where we have access to MRI. I can tell you, my Northern Hemisphere colleagues don't have that. They're still talking about when and how to use MRI. We've been having ready access to MRI now for about 7 years, and that's allowed us to risk modify our approach and minimise harm. So the PSA is the first step always, but then we go to MRI triage, if you will, to decide who to biopsy and who not to biopsy, who's at risk, who's not at risk. And of course, and again, one of the other big changes has been the move to transperineal biopsy. All of you consumers out there, I tip my hats to you, because Australia changed from transrectal biopsy to transperineal biopsy on the back of consumer input. Don't underestimate the power that consumers have in this setting. And as Jeff has already said, NHMRC puts a lot of store in consumer feedback, in public feedback. It's the important part. It's to do with acceptability of guidelines, it's to do with feasibility of guidelines, and that's where you guys really come in. It's science-based, but don't underestimate the effects. So what's changed? We've listened to you, and we've learnt from 2016. We've tried to make these guidelines much clearer and more succinct, and we've divided them into groups of recommendations. The first two recommendations are about talking to patients, assessing risk, and then the next group of recommendations are about PSA testing, and they're written for busy general practitioners, busy family doctors, so it's easy to implement and clear. And then the next set of recommendations are for the specialists, urologists, about using MRI, how to biopsy, and what to do with those diagnoses. Remember, the other big change has been active surveillance. We're a lot more confident about not rushing into unnecessary treatment now with these men. So that's what's happened over the last 10 years. In terms of particular guideline recommendations this time, of course, we now have two strong recommendations. We didn't have any strong recommendations in 2016. We've now got two strong recommendations. One strong recommendation is regarding risk assessment, and the other strong recommendation is for men aged 50 to 69. We believe the literature is strong enough to support a strong recommendation. The other major change, of course, has been in that group. We've moved language from offering PSA to initiate discussion. So if you take nothing else away from tonight, we've moved to initiate discussion, and it's a strong recommendation for men aged 50 to 69. The other headline changes include men as young as 40. If they're interested in their prostate health, they bring it up. We're saying to GPs it's okay to talk about it. Offer a PSA test. risk stratify. You'll hear that theme the whole through. Risk assessment, risk stratify, harm minimisation. I don't think there's anything else I want to say at the moment. I'm sure a lot of it will come up in questioning. Just one other thing that Jeff has said. The important thing, a lot of my colleagues, and I'm sure a lot of you are thinking, how come it's taken 2 years to get this far? The reason is we feel so strongly about getting all the colleges on board, so strongly about complying with NHMRC, because if we do that, we can then influence government policy in coming years, and we can educate and influence the population, the people of Australia, to get this right, get everyone on board, get everyone singing from the same hymn sheet. Thanks, Jeff.
Cheers, Peter. Thanks for that. Appreciate it. And we've got some questions building up in the chat room, which is terrific, and we'll start getting to those in a moment. But first, let's just hear from Anne about next steps, PCA perspective, etc., and then we'll get to the questions. So, Anne, comments from you, please.
Thanks, Jeff, and thanks, Peter. And obviously, I commend the work that both of you have done on this and the countless hours you've put in, and also thank you to everybody in this room who have advocated so fiercely to get us to this point. And I acknowledge people like Alan and Fiona White, the work that they've done over the years, and many of you others who are here today. So thank you. And thank you, Fiona, for the first question there. What I will say, and I'm sure most of us agree on this, is that Australia has failed as a nation in raising awareness of prostate cancer and educating the community over the past 10 and 15 years. And these guidelines provide us with a new way forward to correct that failure. And that's a really important step forward. Prior to the calling of a federal election, we had commenced discussions with the department and with the federal government, with the Minister for Health in particular, about the implementation of these guidelines and what that will mean, and in particular about an investment in very serious funding for a population-wide awareness program and what that might look like. We will pick that up as soon as a new health minister is sworn in, and this will be our highest priority. We'd welcome your input and feedback. If there are any roadblocks along the way, we may call on you to support our advocacy, and we'll be quite public about that. This isn't something we're going to back away from. So in terms of next steps, implementation is key. I can see already that there are questions there about alignment with the RACGP. Our answer on that one is absolutely yes. We recognise that one of the major weaknesses of the 2016 guidelines and their implementation was the inconsistency and the questionable implementation, I'll use that word politely, at the general practice level, and all of you have fed back to us on that. We have absolutely heard you, and we hear it here every day at PCFA as well on our telenursing service, and from our prostate cancer specialist nurses in the community, and certainly from our support group leaders. So absolutely, we're moving forward. Implementation is really important, and this is a discussion that we're having with the federal government. So happy to take more questions about implementation if anyone has any. Thanks, Jeff.
Cheers, Anne. Thanks for that. Appreciate it. Yes, the RACGP, and we'll get to that in a sec too, because I see it's there as a question in the chat room. Just to note, we opened the public consultation, as I say, a week ago yesterday it was, or the day before. Well, so many public holidays, I've sort of lost track a bit. But as at this morning, we've already had 100 people, 100 submissions. Well, 55 complete and 45 approximately partial. They've started but haven't yet completed. So, I mean, we're delighted to see the response, and we're hoping to hear from as many of you as we can. And consumers have certainly taken a lead already. You know, we've had over 30 consumers already provide responses. Certainly we've had, 10 from general public, 9 health professionals, 3 prostate cancer group leaders have already logged on and started to provide us with feedback, which is terrific. And this is what we need to hear. There's generally, overall the response has been very supportive. In terms of providing advice, just for your information about, how we might, what we might strengthen or what we might improve, there's strong strong encouragement to pursue the government over public education and awareness this time round. And Anne's already mentioned that we recognise that was the limitation last time. Certainly targeted education, not just to consumers, but to general practice as well. And that's a message. And we've heard that as well. And it's in the implementation priorities, which you might have seen. And certainly a consumer companion for the guidelines once they're released. And again, you'll note that that is a priority in a high priority in our implementation priorities once we get going. So with those introductory words and moving along, if you're happy, why don't we start with the chat room and work through. Other than that, if you've got your hand up, I'm hoping that with this screen, I'll be able to see you, but perhaps Anne or others, if they see hands up and I don't see them, will give me a bit of a shove. As Anne mentioned, so Fiona, you've come in with the first two questions. Well done. So the first one's about how much weight's given to, evidence-based scientific input as opposed to face-to-face experience. Well, all I can tell you is the NHMRC have specifically requested that consumer input be detailed, and not just in a tick box way, but in a way which is substantial. As I said to you, the single largest group of contributors to the working groups has been consumers. I also point out that we have heard, and Anne has said a lot of these things, those things we put in there about consumer companion, education awareness, and a movement to strong recommendations were all based on a lot of consumer-based feedback, as Peter said too, we've received over the years. So from our point of view, it's critical and will be folded in. And thank you for allowing us the opportunity to highlight that. The next question you mentioned was about, will the RACGP ensure that GPs follow the guidelines? Well, we can't guarantee they'll ensure it, but what we have done is work very closely with them. There have been 10 GPs on our working groups. We have engaged the RACGP from day one. They have provided us with an official representative to sit on the steering committee. We're actually already have established a joint working group with the RACGP, which Peter and Anne and others sit on, to start to develop resource materials to be made available in parallel when we launch the resources later this year, hopefully. So all we can tell you is a strong recommendation in our priorities is RACGP and alignment. We've worked closely with them. They are at the moment very interested in working with us and being, contributing and cooperative and engaged. And we're doing absolutely everything that we can. What the RACGP do in the end is up to the RACGP, but we have left no stone unturned in relation to that. And we've also, by the way, something I mentioned, we've also had meetings with them about revisions to their Red Book, which I know many of you will be familiar with. And Peter and David and myself and others have already been talking with them about that, suggesting they hold off a planned revision until after the new guidelines are approved later this year, so that the new revision will reflect what's in the guidelines.
I might just add there, Jeff, that our great hope is that with these new guidelines, we will improve the agency of consumers and their own awareness. So if you see a GP who refuses to provide you with a PSA test when you've requested one, we should be educating consumers about what their options are at that point. You can call 1-800 for support, talk to any of our team, but you can also seek a second opinion. And certainly that's why organisations like ours exist. Our hope is that with the implementation of the new guidelines, awareness of the services that we provide will improve, and the existence of support groups as well, so that men and their families have somewhere to turn when they may be given a bum steer by a general practitioner. And look, we hope that won't happen anymore, but it may. We exist to help people troubleshoot it when it does.
Yeah, and to just pick up Peter's point earlier again, this draft set of guidelines has a strong recommendation that the GPs initiate a discussion for men aged 50 to 69. Earlier, if they're at a higher risk group, like family history or sub-Saharan African descent. But a strong recommendation that GPs initiate it, which, as Anne said, provides much greater agency. Mark, I'm looking at your comment, which I'm assuming is saying it's a massive one for men under 60, and especially in regional rural areas. We couldn't agree with you more. And again, part of the approach that we're taking in the implementation, and Anne's just picked up on that again, is that we're not going out with this without the government support for a nationally targeted education awareness campaign for the whole community, which will require specific approaches for rural and remote areas, as well as priority populations. So we are certainly going to do whatever we can in that regard. Again, you know, your feedback about that in the consultation through this process will help us. So please feel free to reinforce that. And Don, well, yeah, it is our hope. We just sort of discussed the RACGP a little. We know they're outdated. They're looking at updating them. We've met with them and discussed with them the utility of waiting until we get these new guidelines, so they don't have to update them twice, which I won't want to do. When we get these new guidelines approved, we're expecting that they'll be consistent with these new guidelines. And at that time, it'll be incumbent upon the RACGP to do whatever they can through their own professional development networks to ensure GPs are made aware. And we, through PCFA and through the government, will do whatever we can through public awareness education campaigns to ensure that that happens, and work with them to develop materials, if that makes sense. I see there's a question there from Fiona about free to total. Peter, are you happy to answer that? The question reads, why don't you use free to total testing at the same time? Makes, you know, likelihood of detecting cancer easier, better diagnostic tool, it's cheap. Can you respond to that, Peter?
Of course, thanks. That we spent a lot of time talking about free on total ratio. As you know, it is in the 2016 guidelines, and it still is discussed a little bit in the European and North American guidelines. And as you're all probably aware, there are other ways of trying to refine PSA to improve its accuracy. Free on total ratio, PSA velocity, the Stockholm 3 test. There's talk. There's research about saliva testing as well. But what's happened in Australia is since 2018, we've had access to MRI, and MRI trumps everything. It's to continue the bridge or the Yucca or 500 analogy. It's a low down misere. It replaces free on total ratio. And our calculations on cost effectiveness were, whilst we might have to do a few more MRIs, the money saved will be quite significant in improved diagnosis. So that's why we're not stipulating free on total ratio in these new guidelines, because MRI has replaced it. Now, it may be that in 5 years' time, a new blood test or an improved PSA test comes along, and then we will keep modifying. And that's the other thing I want to say, is that we want to put in place a review mechanism every 2, 3, 4, 5 years to keep updating these ideas. But at the moment, in 2025, MRI replaces free on total ratio.
Okay. Thanks, Peter. Peter, while you're on a roll, there's a question in there about the 2-year period for testing. Would you be happy to just handle that one while you're on the go?
Sure. Well, as you know, the 2016 guidelines recommended 2-yearly PSA testing as well. The 1-yearly PSA testing is a legacy from the MBS for many, many years ago. And it was only recently changed to comply with the 2016 guidelines. If you look at the literature on PSA testing, particularly the European literature, most of the literature on screening used either testing every 4 years or every 2 years. The strongest information was on 2nd yearly testing. That's why we've stuck with that, because the literature supports it. There was some single testing PSA, but that did not show any effectiveness. And I think the PLCO, the American studies, they were using 1 yearly PSA and rectal examination, but showed no benefit, no significant benefit in prostate cancer mortality. So that's why we've stuck with the European studies, particularly out of Sweden and the Rotterdam group, who are using 2nd to 4th yearly PSA, and the PSA in the range of 2.5 to 4. So we've kind of gone 2 years, 3, to try and wind it back as close as we can to get more people in tested.
Thanks, Peter. And look, do you know, again, that's where we've started with what we can find in the literature from trials and evidence. But again, the public consultation is an opportunity to make a case. And the more that is made, then the greater the strength of our submissions to NH and MRC and elsewhere.
And Jeff, can I just mention that you and I had a conversation about this earlier today and agreed that it may be appropriate for PCFA as the voice of many consumers to actually make comment on this ourselves in response to the release of the draft. We're well aware right now, and the new draft guidelines do give GPs the opportunity, if they feel it's appropriate, to undertake annual testing if a man is considered to be high risk at prostate cancer and if clinical assessment warrants it. And perhaps we can strengthen the language in the guidelines about that. And so we'll certainly look at that. But please do provide us with your strongly worded comments on that point, and we'll carry it forward. The other thing that we would like to say is that in terms of ongoing research into this, we will be looking at the number of cancers diagnosed in that interval period. We do that with other cancers already, and there's no reason why we shouldn't do it with prostate cancers. And if we can build the evidence base to justify yearly testing for more men, then certainly that's something that we will be looking at in future, and hopefully these guidelines will become a living document where we can update them more rapidly than every decade. So we appreciate your support with that, and we very much appreciate the strength of advice that's been put into the questions here today and in the early comments received back.
Yeah. Yeah, again, I can see Alan Barley on the screen. I just got a thumbs up from Alan. Alan, by the way, is on our working groups. But please do take the opportunity to provide us with that feedback. It does, I mean, it does make a difference.
It influences what we do. There's no doubt about that.
Yeah. Let's move to some hands for a while. I'm not quite sure what order they appeared, but how about Paul? Maybe can we go to Paul? You happy to kick it off, Paul?
Yeah, so I'm from Fremantle, and I'm quite new to this. Although I'm 75, I've only just discovered that I've got a prostate reason for concern. So I attended my first meeting of the Fremantle group yesterday, and what immediately struck me was, why isn't PSE just part of the standard blood test that I get every year from my GP? And it seems to me then that the one way to deal with this is that at the age 40, it just becomes one of the standard list of items in your standard blood test. So as a consumer, I have no idea what my blood tests are. There's this long list of, often Latin names, which mean nothing to me at all, but I trust my GP that they know what to do with it. But the other positive side of it is these days, the pathology actually flag things that are are out of range. And although that's not a perfect thing, the fact that it's flagged, it means that both the consumer and the GP get a flag. So it gives both of us then the opportunity to raise it with one another. So I think rather than then initiate it being the role of the GP to initiate it, we can use the standard blood test as the mechanism, the process for triggering that initiation. So if that was to be something that was initiated from all men from, say, 40 onwards, it's just part of their standard blood test, we start to get a decent history, which I don't have, of PSA tests, and wish I had, because it would have probably alerted my GP to reasons to take some action, 20 or 30 years ago. And I feel that that's something that would be simple to do, and a rule of thumb that at 40, it's just part of your standard test, and it may trigger a conversation from your GP if the results are worth talking about.
Well, Paul, look, thanks for that. So, I mean, Peter and Anne may well want to comment as well, but I suppose what we see in this version of the guidelines is for men at higher risk, GPs be with a strong recommendation to actually initiate that discussion. So it's a GP initiating that discussion for men at higher risk, so family history, etc., at 40, as you've said, and for men with no symptoms at usual risk, normal risk, not average risk, to start that discussion at 50. And it is saying initiate. So it is. I'm not sure if there's every GP has the same set of blood tests, but what this recommendation says is that GPs for a man who comes in age 50, no symptoms, no family history, should say, how about a PSA test? And that's a big shift.
Well, I don't need. I understand why there's any need to ask for permission. You know, when I go to see my GP, he doesn't say to me, "Do you want to have a liver function test, or do you want to have a globin test, or whatever it is?" I don't want to have that conversation with my GP. That's my GP's job. I just want them to say, "Look, you're 40. Let's include a PSA test." I don't think it's going to add any cost in terms of, you know, the testing at the path lab. It's just one of the standard tests that they do, and it's just they report on it. So why not include it for all men from 40 onwards? And one of the things it does is that it then means that it's not a big deal. You know, the fact that you've initiated the test, it's just part of being, you know, the normal consumer GP relationship. And so that we start to then, if you like, defuse the C word. You know, it's not then a worrisome thing of we're only doing this because we want to make sure you haven't got cancer. It's that we now do this test because you're 4 years old, and let's get on and do it.
I might just comment there, Paul, that the risk there of not requiring the conversation carries with it fairly significant risks on the patients because of the different thresholds for men based on their individual risks. And I can give you a good example of this. In last week, we were advocating to get a refund for a gentleman who had been incorrectly billed for a PSA test, where his GP hadn't been aware that he had a family history of the disease and that his father had been diagnosed. And I'll read you the note that the GP clinic sent back to me. Please note, the doctor is in fact aware and up to date with all the current Medicare billing item numbers. Had he known the patient's history, he would have marked the tests accordingly. My question for the doctor is, why didn't it occur to you to ask the gentleman about his family history? Now, this is what happens when you cut out the process of the conversation and just make it an automatic test yearly. If there's no conversation between the patient and the general practitioner, it means that risk factors can be missed. And I guarantee you, we see that every day on our telenursing service and when we talk to our nurses. So we have to be really careful that, consistent with the new draft guidelines, the initiation of the discussion is absolutely key. I can give you another example, which is reasonably well known. Will McDonald, who was diagnosed at age 42 with advanced and aggressive prostate cancer. His father had been diagnosed and nobody told him, his GP did not tell him, that he was then facing double the risk of his own diagnosis. Now, these are classic examples where the engagement between the clinician and the patient is absolutely critical to survival and an early diagnosis. So what you don't want to do is mandate a process that will have unintended consequences. And potentially, if you don't have a GP who's well educated on the risks of prostate cancer and doesn't have a high volume of patients who are in a particular risk group for this, and I can think of bulk billing clinics in Sydney that fall into that category, then you're creating risks for patients and for men in our community. So Jeff's earlier point about the importance of that conversation is a really important one, and do not underestimate the importance of understanding your family history, particularly in a country where men in socioeconomic disadvantage, for example, are jumping between bulk billing clinics, and you may not even be able to monitor for things like the doubling time and what that may mean. So there are a whole bunch of risk factors here where understanding the individual's risks becomes critically important. So those would be just some factors to think about it. That there is no easy solution to this. This does involve an assessment of individual risks and a conversation.
All right, look, thanks, Anne. Paul, we might have to move on. There's other hands up, and I think we've dealt with that a bit. What I might do, if we go to Gary and then Alan and then Greg from hands up perspective, and then we might see if we can take some more comments in the chat box. So Gary, you ready to go, mate?
Yeah. Thanks, Jeff, and congratulations to the PCFA on producing these guidelines. I wish they had been in place when I had my discussion with my GP about PSA levels and PSA testing, and for quite some time he wasn't really interested in getting a PSA test, and I virtually had to convince him of that. And it turned out subsequently that I had a very aggressive prostate cancer. So I think it's a great piece of work. And I like the risk assessment approach. I come from a background in occupational health and safety, and risk assessment is the key framework within that context. And I understand the importance of that. And I also recognise that it presents a bit of a challenge in that I'm just wondering if you've thought about perhaps piloting the draft guidelines with a group of GPs that haven't been directly involved in its development to see how they go, give them a couple of case examples and see whether they can apply them and get some feedback from that process. It's just a suggestion, but I think it's a giant leap forward. And also I applaud the fact that you're going to try and update them every 5 years, because I recognise that this is an area where technology is rapidly advancing, and there are different types of testing being mooted here, there and everywhere, including saliva testing, which I think is still a bit problematic. But maybe in 5 years' time, the technology will have moved on. So that's good. The only comment or query I had is that there's quite extensive appendices and a lot of information about the governance structure and the previous guidelines and who was consulted on the previous guidelines. And that's all very important information. But I guess at the end of the day, when the guidelines are completed and signed off by the NHMRC, do you still intend to include that information in the guidelines, or would that be better placed perhaps in a discussion paper or information paper? And, the evaluation, how you're going to evaluate the guidelines, and increase, information, education and awareness training and all those things, which are terribly important. But I assume will change and be quite dynamic. And so I wonder whether you would have sent those things in concrete within the guidelines themselves. That was my only query.
Cheers, Gary. Well, thanks for the feedback. And again, about GPs, that's why we got so many of them involved from day one. And we really need the college on board to help educate GPs to implement. That's why we work to make them clear. Look, in relation to the format of what we put out there, the material that's been put out for public consultation is entirely consistent with NH and MRC requirements at this stage for approval. So, the technical reports and all that stuff are required for people who have an interest in that to comment on that. We might get pathologists and others doing all that sort of stuff, or people are interested in governance structures. So that's all there. We assure you that once we have approval, we're working on plain English versions. We're working on consumer companions, working on one pages for general practice. All of these sorts of things need to be produced and made available, which is why the implementation stuff is so important. And we will make sure that all of that happens. Of course, we can prepare we can start to prepare, but we can't actually complete it until we get an approved set. So it's doing what we can in advance and being ready to hit the go button once we know exactly what we're working with. But rest assured, there'll be plain English, consumer versions, stuff for GPs, awareness campaigns, and all of those things that weren't available when the 2016 ones came into play. Thanks for that, Gary. Alan, you got a query, mate?
Yes, thanks, Jeff. Look, I just want to reflect back on Peter's comments earlier about the European studies and the other ones. I've read them both, and I understand the timelines, but I'm sure as many of the people on this Zoom will know here of blokes who were told to go away on a holidays and come back 3 months later and it's gone aggressive. So there is a call for every 2 years. But I'm like a dog with a bone at the moment, Peter, because of my own personal experience of having 1.9 PSA level for a man nearly 60, see in 2 years. But my free to total, which I keep banging on about, and I will continue to do so, was 12%. And then my yearly DRE, the Guidelinesfor biopsy, and the rest is history. And I hear about the MRIs, they're really a game changer and it's fantastic. But I feel waiting to get to 3NG when the baseline, that first initial PSA plus the free to total would automatically light up a red flag where a bloke has got a low PSA, but his free to total's dropped. And there'll always be a nuances to that. I understand that. But I'm saying if we're doing a PSA, an initial one at 40 or whatever the age be, do that free to total to get an idea and a baseline and then work from there. And we may even catch men even earlier and then send them for an MRI, which may prove to be incontinental. So that's just my bugbear, because I feel if we're waiting for 3 and then doing another one and then going an MRI, they could have been maybe caught 12 months to 2 years earlier. And everyone has their own ideas. That's my bugbear, that and there are other ones. The spit test is coming online and other tests will help to refine it even more. But if we're starting from a ground level, especially for men in regional rural areas who are getting missed out still, that is my particular bandwagon, I guess, Peter, and I see benefit in that one being done personally.
Right. Thanks, Alan. I appreciate you raising it. Peter, you want to comment? Any views?
Oh no, I wish, I wish we could do PSA free and total ratios on every man who lives in Australia from 40, and if they've got a family history, do it sooner. But politics is the art of the possible. It's what we can do, and we just have to try and cover as many people as we can. But listen, give us the feedback, put it in there, and then we can pass it on to NHMRC. You'd be amazed at how much strength that gives us to keep on keeping on. Make no bones about that.
Yeah, and Alan, please do, mate, because it helps us if we get it in this consultation phase. Hey, Greg, all the way from ACT. How are you, mate?
Doing extremely well, and I've got to admit that seeing your happy, smiling face beaming on the screen to me makes me feel 3,000% better. And I'm glad to see you in the position you're in. Thank you so much.
Cheers, mate.
And look, I just simply wanted to say a massive thank you to yourself, to Anne, to Peter, and all the other people involved in the current position that we've got to with the review of the guidelines. I was extremely heartened reading through some of the information and seeing some of the wording that reflected some comments that I made in my speech in that courtyard in Parliament House 3 years ago, and to do with the fact that knocking this thing on the head as being an old man's disease, and early detection and getting out there and letting people know about the risks so that they can have intelligent conversations with their GP. So look, I've spent 3 days going through, I guess, the first couple of 100 pages of the review, because it is quite intense, and it's important to try and gloss through it and pick up what you feel you do need to comment on. But it is incredibly detailed. It's a great stepping stone, and I think moving forward that will make a difference. I guess as always, being the impetuous individual that I am, and Anne will probably attest to that. My concern has always been that every day that we've not had this opportunity to have these conversations, that the number of men that are being diagnosed too late at a metastatic level. So hopefully we move forward. I guess one interesting question that might be worth asking at this point, if we can get an answer on it, is that from this place where we are now? How long will it take us to get to a point where we can actually move forward and start to get this thing out there and implement it?
Okay, so Greg, terrific stuff. Thank you for those comments. In terms of timeline, our timeline is this, to get it to the NHMRC. The public consultation is open until 25th of May. We will be collating submissions all the way through, updating, and as questions arise, we'll be seeking answers to those. We'll be updating drafts. We'll be going back to our working groups. So we will have a next version of this as soon as possible, based on the consultation after the 25th of May. We give ourselves then a month to prepare a final submission, which we need to have to the NHMRC in June. The exact date escapes. Oh no, it doesn't escape me. I've got it here. We have to have it to the NHMRC on the 23rd of June. It can't be any later. That is their deadline for consideration at their August council meeting. Now, a number of things can happen at the council meeting. They can approve it outright. They can come back with questions. How long it takes from that point, Greg, depends on what happens at NHMRC. It's our hope that we've got these approved certainly before the end of the year. As I said, we've followed every step closely and overperformed on requirements. So we will ensure that we push the MRC for as early as possible determination so that we can get on. And as you say, every day, every day sooner, it's more people getting detected. They're getting their prostate cancer detected earlier, and that's what we need to do. So we're pushing hard with it, mate, and we'll be advocating behind the scenes in the media and with the NHMRC directly until we do that. Look, there's a few more comments here. We've only got a couple of minutes. Peter, I know you'll want to talk about this one. It's about DRE. Haven't heard any reference to DRE. Where is it in the guidelines and what's our position?
Sure. These guidelines for the early detection of prostate cancer in asymptomatic men. And the literature is very clear on this. And I can tell you as a practicing urologist, I've been doing that lots and lots of times over many, many years, over many, many men. And I can tell you as a screening tool, it's not very good at all. It's about the toss of a coin. And our concern is, and there is literature on this that supports it very strongly, that the threat of a DRE stops men from coming to their doctor for a blood test. Now, don't confuse that with men who have symptoms. If you have urinary symptoms, difficulties, a DRE, that's fine. That we're not saying don't do DRE, but what we're saying is to GPs, to the general public, a DRE is not a good screening tool. Don't be put off by that. Have your blood test. Is it perfect? Of course it's not. But we feel that on balance, we'll get more men to come in and have their PSA blood test if the threat of a DRE is not hanging over them. If you want a DRE, ask your GP for it. We're not saying don't do it, but we're just saying don't let the DRE be a block to coming for a PSA test.
That's right. And just a reminder that DRE was not recommended in the 2016 guidelines either
Correct.
At GP level. So
Correct.
And we've seen plenty of GPs get it wrong. Plenty of GPs who don't know how to do a DRE and give men a false sense of surety that they don't have prostate cancer, and in fact they do. So we've got to be.
Well, let me tell you, Anne, in the era of the MRI, let me tell you right now that I'm right maybe 20% of the time. Most early curable, completely curable prostate cancer is not palpable. You can't feel it. And often when a prostate feels firm in the rooms, when I take them to the operating theatre, there's nothing to feel. So it really, it's difficult. I know there's been comments there from several men saying they were found through a DRE. Fantastic. If you want, I'm not saying DRE must not be done, but I just don't want it to be a barrier to men to get the blood test.
This again explains why you've got 600 odd pages of evidence packed into these guidelines, you guys. This is complex. And really important to remember that there's no easy solution to any of this, which is why always these conversations are.
All right. Hey, look, thanks. Look, everyone, we're getting close to the time. I'm just looking through the comments. There are a number of discussion points in there about annual testing. All I can say, please take the opportunity to make that point in the public consultation. I think that's critical. For those with an interest in promoting, the free to total work, take the opportunity in the public consultation to put that through. I think this is the opportunity to stress, because as I mentioned before, NHMRC, you look at published literature and clinical practice for evidence. They look at community context and they look at consumer feedback. Your feedback allows us to make a stronger case with regard to certain matters. And we have already used your feedback in the implementation priorities. And I'd ask you to please look over those again. And if the opportunity presents, send in some feedback which says, yes, you've got to have a companion for consumers. You can't forget it if you're not going to do that. You must have education awareness campaigns. We must continue our research efforts. Those sorts of things are in the implementation priorities. So please have a look at those again, and let's make sure that if there are things you want to say, let's make sure we don't waste the opportunity. To pick up on one of our earlier questions, every bit of feedback has got to be logged, it's got to be recorded, and it's actually got to be, we have to actually address it one way or another. And then that has to be submitted to the NHMRC as well. So to pick up an earlier question, every bit of feedback will be read and we have to deal with it in one way or another. And we have to explain what we've done to the NHMRC. So I think this is the opportunity. And Peter, look, with that, and with a minute to go, what I might do is just, final comments. I think, and I'll come to you in a minute, just from a wrap up from PCFA perspective. But Peter, any final word from you, my friend?
No, just get in there, write to us, give us your opinions. We do listen to them, we want them, and they are very, very helpful, I promise you.
Cheers, mate. Anne?
Just to thank you all for being here today. And look, we will respond to all of the questions in the chat. And if you do have additional questions, please email them through to us. We're happy to organise another webinar like this one to circle back and then answer any ongoing questions as this process unfolds. So it's been fantastic to see the level of engagement today.
It has been. So cheers, everyone. And remember, if you haven't already been there, you can go to the PCFA website and there's a link there for the public consultation. Log on, there's instructions. If you get stuck, let us know and we'll help out. Please take the chance, take the opportunity. Anyway, good evening, everyone. Lovely to see the familiar faces. It's been fantastic. Thanks for everything. Good night.
Thanks, everybody.